Let's start the show. Hello, everyone. Welcome back to Luncheon with the Experts, a Carcinoid Cancer Foundation program brought to you by Ipsen Biopharmaceuticals. My name is Rain Bennett. I'm your host. Welcome. I'm a filmmaker, I'm a writer, and I've been working with CCF for 10 years, folks. Every time I say that, it's still shocking to me. Since what years is 2022? I think we're going on 11 years now. And we've created video content. We do live video series like the one that you're going to watch today. We create produced videos, documentaries, all sorts of content, but all with the same mission in mind, and that is to educate people, to raise awareness about neuroendocrine tumors. That is what we're here to do. That is what this show does. We'd like to provide you with some good guidance, some good answers to any questions you have. And also, as I was mentioning to our guest before we started the show today, I'm really proud of the community that we've cultivated here within the show, that the foundation has been growing for 50 years now at this point. But we appreciate you all being here. And if you're a regular to the show, I see many of you are, and you're already saying hello from Virginia, Arizona, Pennsylvania, New Jersey. If you're new to the show, tell us where you're signing on from. We love to see how far these programs reach inevitably every week. I see people from all over the world tuning in live, and that makes us so happy. So we appreciate you being here. Say hello to the people in the community. I promise you, your relationship with them will be valuable. So before we get started, we always want to thank our sponsor, Ipsen Biopharmaceuticals. Listen, without their support of Luncheon with the Experts, we wouldn't be able to do the show. We also like to include this disclaimer from them at the top of the program. And that is that the opinions expressed by the guest presenters, as well as the questions asked by you all, the audience, haven't been created or suggested by the sponsors of Luncheon with the Experts. And CCF doesn't endorse or promote any of the views, opinions, or information provided in the presentation. Audience members should not rely solely on the opinions or information expressed by the guest, and should seek guidance and direction from their own medical advisors regarding any choices they make about their health or treatments. Folks, that last line is really the takeaway I want you to latch on to. We're going to give you some good answers and general advice, answers to your questions, but by no means do we or our guests know your specific case. So take those answers, take that advice back to your home team, which does, and make the best plan and path forward for you, because as we know, each case of this disease is unique, and therefore each plan and path forward is as well. So today our guest is Dr. Mary Maluccio. I'm excited to have her back. She was here previously, which now is like years ago, which is wild. Feels like a time warp. In the early days of COVID, when we were doing the predecessor to Luncheon with the Experts, a Facebook Live program, and we did one specific few episodes on, hey, how do we navigate this thing called COVID? It feels like that was yesterday, but guess what? It's been 2 years ago. Dr. Maluccio, welcome back to Carcinoid Cancer Foundation, and welcome for the first time to Luncheon with the Experts.
Yeah, thanks for having me, Rain.
Absolutely. So for the folks that aren't aware of you or where you work, what you do, tell us a little bit about yourself and the role that you play in this neuroendocrine tumor community.
Okay, great. So I am a surgical oncologist, so someone that operates on cancer for a living. So I'm a surgical oncologist, very much interested in what I call marginalized patient populations. Those are patient populations that are kind of pushed to the periphery of mainstream medical practice. And it can be for a variety of reasons. It could be, rural communities, regional medical center, but rare cancer patients are by definition marginalized because their outcomes are often dependent on them finding someone that is familiar enough with the disease to give them good advice. So I'm really like 20 years into my career, always sort of focused on marginalized patients. I got interested in neuroendocrine probably, around 10 years ago. It does seem like yesterday, around 10 years ago, when we were sort of thinking about outside the box treatments for neuroendocrine patients, like transplantation, that was quite controversial at that time. And then I just really became really that much more committed to this particular patient population. So I moved to the South, and a lot of people, they're familiar with our program. I am the medical director of the neuroendocrine program in New Orleans. It's one of the largest neuroendocrine programs in the country. And it was at a time when there was the retirement of an icon in the field. So you can imagine the burden on my shoulders. So around 2.5 years ago now, I took the helm of this program with really a couple of main objectives. One was to shepherd the program into new leadership, but was also to increase the stature of the program such that we could bring novel treatments, clinical trials, a little bit more, research components to a program that serviced a lot of patients. So my professional niche has been in cancer programmatic development. Some of my passionate things actually have nothing to do with surgery and are about non-surgical treatments for metastatic cancers. And we talk about that every day in this patient population in particular. So I've been here for 2.5 years. When I was last on your program, it was probably 3 months into my tenure, and COVID in Louisiana was fire engine red on fire. And now I'm coming in 2.5 years, and I think a lot more seasoned, a lot more familiar with this part of the country, and obviously a lot more familiar with this program. So,
and the retirement that you were referring to is Dr. Woltering, is that correct?
That is correct.
Yeah, definitely a titan in the community. In my early days with CCF, working with CCF, I got to interview him and meet him a couple of times, and what a beautiful soul, awesome character. He's great. And folks, I have spent some time at the NOLANETS program, and it is it's pretty amazing to see their facility. And Dr. Maluccio, I have a comment from Randy who says, Dr. Maluccio is awesome. Well, Randy, I have to agree with that. That's why she's our guest. I have lots of questions myself. I love some of the things that you've already mentioned. I know that we're going to get questions about the marginalized communities or patients, because we hear these every week about patients that are, far out in the country. They're not near a net specialist center. Their doctor hasn't heard of this or really doesn't have much knowledge of it. So I feel like we're going to get some questions about that. And I'm really excited that that's a passion of yours. We have amazing numbers already. 86 people have joined, which is great for this early in the program. So folks, listen, go ahead and start sending in some of your questions now that Dr. Maluccio has kind of laid the foundation of where you're going to get the most benefit, but she's told me that nothing is out of bounds, rather. You can ask her anything. Obviously, she's a surgical oncologist, so you're going to get a lot of benefit there, but she already said her passions also extend out beyond that. So great resource that we have today. And really the most value that you'll get out of this program is this interactive one-on-one session. We're going to post this. It'll stay on Facebook. Starting Monday, it'll be on YouTube. You can always watch the replay and get some value there, get a lot of value there. But the real benefit is getting a question across that you've been struggling with, your team has been struggling with. So if you know someone that should be here right now, that this is important information that they could benefit from, go ahead and tag them in the comments. You can share the video of their page. Let them know what's going on. We want to get as many people here as possible, because again, side benefit, the secondary benefit of this show is the community and sharing the experiences, your own experiences and stories in the comments. I see it every week. Someone has a question. They can't figure something out, diet-based or whatever it might be. And someone chimes in, hey, so-and-so, I tried this. It was really helpful. Those sorts of things really help this journey as well. Another thing I will ask from you all, I ask it every week, you do a great job of it, is if you see a question in the sidebar that you also have or you're interested in the answer to, just under the comment, you have the option to like it. And if you hover over like it, it'll give you other reactions, emotional reactions you can use. They all work the same way for me, folks. And that is to effectively upvote that question. If I see that 7 people have the same question, as I'm going through them, I'm going to know there's a lot of demand. I'm going to make sure I get that question across. Inevitably, we can't get to them all because we have lots and lots of questions. That's why we come back and do this show every week. But that's a really good way to help me help you, indeed. So if we don't get to your question, I just urge you to follow up with CCF. We'll try to everything they can to get you that information. But yeah, if you can get your question in across, we're going to do everything we can to get you that information. We have a great guest today. Paula says, hello from Chattanooga. Paula, I went to Chattanooga recently for the first time. What a beautiful little city. That is just, it was awesome. I just took a little jog around town. It was amazing. So Dr. Maluccio, I want to talk a little bit about, you had talked about when you first started around 10 years ago, right?
Yeah.
Right. Correct. That's yeah. And I talk about this. We talk about this on the show a lot. The progress that has been made in this past decade alone. Can you talk a little bit about what it was like stepping into this space 10 years ago versus someone who may be stepping in today, or, you know, what you've seen in that 10 years amount of time that excites you in terms of your ability to do your job effectively?
Oh, okay. So yeah, so I've actually sort of got a story about that. So
Yeah, great.
and when I was asked to sort of get into this market from a programmatic standpoint, it was because people like gene altering were asking us, a very large transplant program, to transplant some of patients that had consequences. They were either had consequences of the disease itself, or more commonly, it was that they had consequences of years, excuse me, 10 years or more of treatment of the disease that ultimately takes its toll. So my then leadership person is saying, hey, Mary, do you think it's reasonable to consider that as an option? And I said, absolutely. When you think about it from an oncologic standpoint, there will definitely be patients that would benefit. But I told them, I was just like, be careful, because there's a whole community and or doctors and patients alike that are going to care. Like they're going to like, you know, have bullets to fire if they disagree with that. And it was controversial. And if you recall, this came bubbling up with Steve Jobs, because was transplanted and yet still succumbed to the disease. And so it's a little bit emotional. Transplant is emotional, but as a programmatic development person, you kind of have to eliminate the noise and just try to look at a resource and where it would be appropriate in a patient population. And so early on in that, we didn't have some of the treatments we even have today. And so therefore, there was going to be a subset of people, and there remains a subset of people that are appropriate for that somewhat outside the box approach. But if you were to fast forward even these 10 years, especially with the emergence of radioisotope treatment, that's the PRRT, and how that seems to be evolving much faster than we anticipated, all of a sudden you have to rethink and you'd be like, well, hold the phone. We go with such an aggressive surgical approach, really life-changing if you're doing these major surgical procedures, or do we have to shift and say, oh, no, they're these things that are coming, that are not only now available, but they're coming down the pike and evolving as a really great option for people. So that's why, and when you thought of us as a neuroendocrine program in Indianapolis, we were really kind of a one-trick pony. Then we were expanding to meet the needs of the patients that weren't appropriate. So it wasn't like we only did that, but that now that I run a neuroendocrine specific program, I still have my people that are my transplant people, because we don't do that here, but that I have to then like navigate all the other things. But I have to admit, that's actually what I really like doing. So that for a patient that's being treated, I just feel like it's super important, even if it's just to get a second opinion. It's super important that the people that are giving you advice are not so tunnel visioned like we kind of were, early on.
Good point.
So tunnel vision towards what they have available, but that of all the things that have evolved over probably the last 5 or 6 years. And I think the blessings of COVID, if we could say anything about the blessings of COVID, is that we do a lot more of this tech stuff. People have a lot more ability to get virtual advice. The programs, the national, patient-specific conferences are now available to a wider range of people because it doesn't require them to come in person. So I feel like we can use some of the lessons we've learned to give people a broader view of what's out there, and then hone in on why one or the other makes more sense in their specific case. Because the one thing about neuroendocrine I've learned is that you may think you're exactly the same as your neighbor that's got neuroendocrine, and 10 to 1, there are going to be nuances to those cases whereby the whole concept of personalized medicine is really important for this disease.
Great information. That spawned a lot of questions in my mind, but I don't want to take up any more time myself because we have a lot of questions coming in from the audience. I'm going to pivot to them for the moment. Our first question comes in from Steven. Steven says, generally, Carcinoid liver metastasis often appears next after primary tumor removal. What liver surveillance do you recommend for early detection of liver metastasis? Gallium-68, MRI, blood test. How often, for how long after primary removal?
Okay, so that's a good question, because neuroendocrine is really about guidelines and not standards. So when you're talking about the more common cancers, this is all about marginalized versus common. Common cancers, there are established clinical pathways, and this over this amount of time, whereby then we do less. Well, neuroendocrine, because it's often slow growing and things can crop up much later, you have to survey people for longer, and you have to anticipate the likelihood of something happening. So not understanding the exact primary site of that question, small bowel primaries are the most common to develop late metastases to the liver. Yet we don't sit there and hover over the liver as if we're Debbie Downer looking at the glass half empty, when really that patient population is about looking at the glass half full. So the guidelines are really about cross-sectional imaging, which is usually a CT scan of the abdomen pelvis with contrast. We do it every 6 months, so a little bit closer surveillance in someone with a new diagnosis, even if the primary has been removed. After a few years, we'll push it out like to annually up to a certain number of years, maybe 5 years or 6 years. There is some blood work that we also follow that also has its own debatable, things out there in terms of who uses it and who relies on it more or less. But that in people, so let's just look at the people that have never had evidence of liver metastases. The standard surveillance is CT scan, the abdomen pelvis with contrast. That's the standard surveillance for almost any GI cancer. If you've ever had evidence of liver metastases, then we use an MRI of the liver, which has hands down been associated with a much higher likelihood of picking something up. And then when we get into the PET thing, and I'm going to channel some of the Eugene Waltering, whispering in my ear, is that we followed people and treated people for this disease for decades before having this PET scan that everyone then gets as is. And so although the PET scan is extraordinarily valuable, I get a PET scan it's not like it's absolute, but I get a PET scan in anyone that has a node positive primary tumor, because the node positivity is the risk of there being micrometastatic disease. So you need a baseline needle in a haystack scan in order to better understand where we sit. So it doesn't change. This is exactly what I tell patients. There are favorable aspects of low-grade neuroendocrine tumors, is that they're slow growing, people live a long time, even in the setting of metastatic disease. The less favorable aspects are that there's this ongoing risk of something happening even years after resection of a primary. They're in surveillance up to 10 years. And there's the burden of that on people that to get diagnosed with a cancer. And for those patients that are symptomatic with a neuroendocrine syndrome, there's a lot of dietary and behavior modification that sort of to keep those that are required to keep some of those symptoms in check. But none of those unfavorable aspects take away from the favorable, but that I tend to sort of focus on those, because if you do look at the support groups, they aren't sitting around the campfire singing kumbaya over all the favorable aspects of this disease. They're focused on how the burdens of the disease over a long period of time. And there will even be times when we say you're likely to live to die of something else, but that doesn't change the fact that we keep following you. But that was a long answer to a short question. An MRI when people are ever diagnosed with any evidence of liver metastases. We use a scan early on when we don't, but that we quickly shift to an MRI if there's any new findings on the CT scan. And we do to get a baseline PET scan in anyone that has nodal involvement or metastatic disease at diagnosis, but we don't necessarily use PET scans as surveillance, nor do insurance companies pay for it.
Got it. Well, Stephen and everybody else, I told you this is going to be a great episode. Great, thorough answer, and I appreciate your question, Stephen. Folks, if you joined us a little bit late, this is Luncheon with the Experts, the Carcinoid Cancer Foundation program. And today we are with Dr. Mary Maluccio, and we are talking about surgery and all things neuroendocrine tumors. Question, Dr. Maluccio, you comfortable with questions with lung nets?
Sort of. Now,
it's a surgical question.
People that know our program, we did lose the lungnoid guy.
I know.
Still an extended member of our professional family, so all is good.
Definitely.
We still call him on occasion. So absolutely,
Sure.
We do still have certainly a strong surgical lung neuroendocrine program.
Gotcha. Okay. And shout out to Dr. Robert Ramirez. Elizabeth says, can nets be removed from both lungs? And if so, in the same operation, or would that be two different operations?
So that's actually a great question. I'm going to explain all the reasons why in general we don't do that. So lung carcinoids come in two major varieties, typical and atypical. And the only real difference is almost grade specific, but the atypical are more likely to be higher grade, more likely to have the lymph node involvement, and therefore we have to treat those somewhat different. So typical carcinoid tumors are often incidentally noted, maybe causing symptoms very similar to asthma, and therefore that original operation to take out that carcinoid tumor is pretty much to establish a diagnosis and better understand whether or not it's typical or atypical. So the initial surgery to get the diagnosis is the sort of the defining surgery. But we are then very reluctant because for the same reasons, these are slow growing and patients can live a long time. You can't go chopping away at both lobes of the lung, increasing the likelihood of a complication of a disease for which you can live a long time and make it likely to kill you. So how we manage the opposite lung is going to be a lot more tempered. So in someone that has symptoms that we believe are neuroendocrine related, we would treat you with the suppressive therapy, somatostatin receptor inhibitor therapy, that is intended to not only improve those symptoms, but to block and or suppress the growth of the tumors in the opposite lung. Because if you have two, then at the microscopic level, you may have the risk of additionals, and we just don't go willy-nilly on the lungs. But that doesn't mean that on occasion we don't do it, but we look at each thing on saying, hey, we know what this is because we've already got this answer, and then we're going to look at where it is, what's required, what's the gen, and how is it ultimately going to change what we're doing right this very second. And obviously, if that one's misbehaving and we think that one was typical and this was more atypical, oh, well, sure, we're going to need that additional information to make better, decisions or give better advice.
Got it. Thanks, Elizabeth. Great question. Okay, so we talked a little bit earlier, Dr. Maluccio, you mentioned PRRT and how effective it has been. I have a question from, looks like G, says, what would be the options after PRRT? And this is a question that comes up a lot. So let's assume that we've done the typical, number of rounds. And now I don't have any other information about that, but ostensibly they need to do something else. What would be the options to that point?
Okay, so the options are often, I look at it like a menu. So we have a lot of things on the menu at the beginning that may make more or less sense in each individual case. So you look and you say, you put surgery on the menu, even though people would be like, you're crazy, you're not doing surgery. But that you would put surgery and then you would discuss all of the reasons why that makes more or less sense for that patient at that juncture. You have somatostatin receptor inhibitor therapy. That's usually the easiest decision to make in someone with somatostatin receptor avid disease and metastatic, like measurable disease that can't be removed completely. You have cytotoxic chemotherapy, of which there are a number of different agents that we use more or less commonly. More commonly in the higher grade tumors, less commonly in the lower grade, but it doesn't mean we never use it in the lower grade if people have slow growth over time. And then there's the liver-directed therapies. Those are the embolization techniques that are highly effective. It's liver dominant or liver only metastatic disease. And then we have PRRT. So the menu is getting longer now. And so the reasons why that's the advice that's given is often because someone has multi-organ site involvement. And so you're trying to use one strategy to treat multiple sites because that's what systemic PRRT, systemic radiation therapy, is going to do. So after you get through those cycles, there are, you're going to go back to the drawing board and you're going to say, okay, where is it growing? What options do we have for that site? How successful are they? What are the risks and how likely are you to tolerate that? But if you were to just say, so that's why I don't want people ever coming away as if PRRT is some Hail Mary at the very end. It is absolutely unequivocally not. It is one of the things on the menu that may make a lot of sense in a person's case, even if it's the first thing we choose or the second thing we choose. So for those people that have had PRRT, still have somatostatin receptor avid tumors on the PET scan, there are going to be options. You can get additional doses of the lutetium-177, currently what we have available, because that is allowed. And that is not unprecedented because that's how they do it in Europe. Mm-hmm. But you also will have clinical trials that may be like almost here, if not here, in parts of the country where you can get radioactive lead, like a different radioisotope, of which one of the one of the progresses that's being made in PRRT is to come up with other PRRT radioisotopes that may be either more effective, less toxic, or can be given over more cycles or over more period of time because they don't affect the bone marrow, for example, as much. So radioactive lead is the one that is coming down the pike and in clinical trials for people that haven't been exposed to PRRT. But one of the things that we're enthusiastic about with that new radioisotope is that there will be people who have had lutetium, therefore unable to get into a clinical trial using lead frontline, but would get into a trial that is using lead in that patient population. So if that person in particular wants that opinion, they can just call our office. I mean, the one thing patients also don't understand is the people within neuroendocrine professionals, we all get along. Everybody is kind of like, wearing the zebra suit and helping each other out. And so depending on where they live in the country, I would be able to guide them towards where I think they will be able to look at additional PRRT options.
Yeah, that's awesome. That seems to be the case from my perspective. Everybody definitely seems to be a part of the same community, fighting for the same team. I really love that aspect of this community. So I believe Janace, if I'm pronouncing that correctly, if I'm not, rather, let me know. What makes a GI net patient no longer a surgical candidate? I'm guessing due to mass tumors. Yay or nay?
Okay, Janice, or however we're asking that, is that the surgical management of neuroendocrine, you hit the little red button, is all in the eye of the beholder. So I think that's where, once again, a second opinion helps, not because the surgically aggressive programs are going to be like, our surgery way or the highway. That's not the case either. I think that different programs are more or less aggressive when it comes to what they offer surgically. And therefore, the people that do a lot of the more complex surgeries are going to be more comfortable, even with more burden of disease. But I also don't want people thinking that our program down here, which has historically been the more surgically aggressive program, is the only neuroendocrine program that pushes the limits of what you can offer, surgically and or have the technical ability to do it. So I think for the most part is a surgeon can look at imaging and look at a patient, look at other medical problems that may influence the recovery, and decide that they are able to manage that disease surgically. The data was just sort of corroborated because they're not going to be able to ever compare apples to apples, but that at the latest NANETS, I believe it may have been Pommier in Oregon, but don't hold me to that. They corroborated that as long as you can remove a certain amount of the total disease burden, there's no magic to 69% versus 71%, but we could go to around 70%, that you will diminish the tumor burden enough to have a benefit. Mm-hmm. And the benefit may be because somatostatin receptor inhibitor therapy alone is unlikely to be able to handle a much larger disease burden. And so by diminishing the disease burden, you are then just giving that very good standard of care drug a better ability to keep the remaining disease in check. So once again, long answer, short question. It's all in the eye of the beholder. And if you want an opinion, like if they aren't pushing the surgery up front, just get a second opinion and just say, I just want to better understand whether or not surgery is absolutely not an option, why that's not an option, what are the complexities of that case, and then you could always send us or Iowa or whatever. There are many programs mm-hmm. where a lot of the surgeries that would be able to say, no, I agree that in this case the risk is too great for a slow growing tumor. And in other ways, we'd be say, no, I believe that we would be able to meet those treatment goals. But that's a very tough question because it's going to be very specific.
Got it. Thanks, Janace. And thanks, Dr. Maluccio, for being willing to take the tough questions. I told you our audience would bring them. Folks, we were about halfway through with today's show. Our numbers are looking great. We're well over 110 people, up from 80 in the early part of the show, that's the way we like to trend. Which is actually not easy to do with an hour-long show, to have the numbers increase as you go along. It usually has the opposite effect. So that's a good sign for us. How about cardiac questions? Comfortable?
Cardiac questions.
Let's go for it.
Let's go.
We run the whole gambit here. Okay, Sarah, who is definitely a regular on the show, how often do you recommend getting an echo to check for cardiac valve issues? And about 6 other people had this question as well.
Yeah. Okay. And so that is also a guideline, not a standard. So in patients with carcinoid syndrome, there are programs that will get it every year. Okay. I personally don't think there's enough data to support that, but that in patients who have carcinoid syndrome or persistently elevated serotonin levels, I think that it makes sense because it's a non-invasive, easy to get. You don't have to drive 500 miles to get it for an echocardiogram. And carcinoid heart disease is something that can develop slowly over time. And the people that are at most risk are going to be people with persistently elevated serotonin levels, of which there's once again going to be no magic number. But you better believe if someone is running serotonin levels above 1,000, just their disease, even if they're on active treatment, I would worry about the consequences of that over time on their valves. But that on an echocardiogram, it's pretty straightforward to see what that valve looks like. It makes the valve, it doesn't make it stiff, it makes it lax like a rubber band. And so that is much better. If you were to look at progress that's been made, the way that we manage cardiac valves is now going towards the minimally invasive. And so if you know that you have changes that are going to be indicative of carcinoid heart disease, then it's much better to establish that relationship early so that you aren't then waiting until you have all of a sudden your body is dealing with the consequences of that. Now, if you were to say the controversy in that is whether or not all carcinoid patients have to be followed with echocardiogram. Well, the answer to that is no. If you have a baseline echocardiogram that shows that your valves don't have any of those changes that would suggest that however many years you had the disease before we figured it out, did not develop those things. If you do not have signs and symptoms of carcinoid syndrome or elevated serotonin levels, we have no reason to believe that you're going to all of a sudden develop those. So once the disease is out and we've normalized that physiology, then getting echocardiograms every year is just like getting another test that winds up being normal. And we would then actually be getting the cardiac evaluation more for all the other reasons you get an echocardiogram and not for the carcinosis.
Got it. Still going all over the place here. Lori says, I've taken so many scans with dyes. How hard are these dyes on the kidneys?
Yeah, well, that's actually a really great question too, because if you were to look at pediatric cancers, there is extraordinary controversy on how we survey the pediatric patients and the influence of the radiation and some of the dyes on someone that's going to live a long time. And the neuroendocrine patients have that same problem. So that's where I have to admit, I say that the PET scan has helped us out. So an MRI dye is the MRI is not the radiation issue. The gadolinium is a dye, and we need that dye in order to give us adequate enough images to evaluate for residual cancer. But the dye is far less risky when it comes to contrast allergies or kidney problems. But the PET scan, on the other hand, is completely safe. It is radiation, but not significantly more radiation than the CT scan. And so then the PET scan comes into play. Every single person that walks this earth starts to have decline in renal function after the age of 40, nothing we can do about it. So you could be a marathon running 75-year-old, and the risks associated with medicines that are kidney toxic or contrast that are kidney toxic. And so we will change the way that we put value on surveillance imaging based on comorbid disease. You can have 50-year-olds that have chronic kidney disease where I'm not going to risk giving them that iodinated dye. And I would just move to a PET scan, knowing that it is more than we probably need for that case. But at the end of the day, we can't make surveillance riskier than the disease itself. And so once again, just like you and I know, a lot of those decisions are very much patient specific. But I want people to know that we realize that we're giving them not only radiation and dye when it's a CT scan, and that we don't just do that willy-nilly, and we will change the way that we may survey someone just based on that risk.
Got it. Thank you so much for that. And thank you for your question. Wendy says, I've learned so much over the last 2 years. Thanks, CCF and Rain. Oh, that's awesome to hear, Wendy. That is what we are here for. Next question, Dr. Maluccio from Mary and a few other people. In view of the greater awareness of NETs of the past 10 years, how are medical schools handling the education of their students in reference to NETs today as compared to the past where there was very little emphasis on NETs? It's an interesting question.
Well, not being on the education side of thing, I'm probably, I hope maybe someone's not listening that I'm going to piss off, but I don't think it has changed one iota.
Huh.
So
you think it
I
should?
don't think, because I think medical school is about teaching someone about the common, because ultimately 99.9% of all of those medical students are going to go into fields whereby they may never see a neuroendocrine patient over the course of their professional lifetime. So I agree with that. I'm just saying that like a lot of things when it comes to education, about trying to educate people to deal with the day-to-day reality of whatever medical practice it is. And at a medical student level, you're just trying to give them the basics because you have no idea what they're going to go into. Now, fellowship training and whether or not you go into medical oncology, I believe that has changed, but that's out of the medical student's evidence. So if you are a medical student, then you go into primary care, well, that's where we're going to have a void, because many people use their primary care, appropriately so, as the gatekeeper for any additional treatment that they have. And if they come in with some of the signs and symptoms of carcinoid, they may say that's irritable bowel. They may say that that's Crohn's disease. They may think that it's more of the common, because at no time during their training did they say, oh, you got to remember some of these rare things. But I also want people to know that when we are learning as generalists, we are supposed to look at a whole list of the differential diagnoses, the common and the uncommon. But I think that gradually, as your practice grows, family practice, primary care, whatever it is, as your primary care goes, your list becomes shorter because you're so used to seeing what comes in your office. So I still believe that neuroendocrine, despite the education, despite the fact that there are so many more resources available for medicine, for medical people as well as patients, they still remain marginalized by the fact that the vast majority of medical practitioners may never see a neuroendocrine patient in their professional life.
Got it. So programs like this are very important.
Yes, I would
to help spread that education.
Yeah, and I want people to know that we actually do also have professional conferences. They're often linked with patient conferences. So before the whole COVID thing came up, you would have these regional conferences. Medical providers would come. So say, for example, one in the South in Atlanta or somewhere like that. We had them for medical people too. I just think that as COVID hit and resources and things like that, that sort of dropped off probably in the last couple of years. But I anticipate we're going to learn a lot of the lessons of how we can use IT to do that. And it may ultimately be that those lessons learned makes us be able to increase the degree of knowledge that's out there just by running one of those conferences that's ultimately.
So let me ask you this. Would you agree, though? It seems to me that the general knowledge has grown a lot, even though it may not change in the curriculum, so to speak. But it just seems to me that the awareness has grown. I don't know if that's just because I'm like involved, in the show, you know what I mean? But like it seems that more people are learning about it or hearing about it. I mean, that's our job, so hopefully so. But
yes,
I don't know if you're seeing
I believe at the upper levels, like when you're talking about your fellowship training, which a lot of people do, your fellowship training in hematology or surgical oncology, absolutely. Now, definitely in radiology, for example, isotope treatment is not unique to neuroendocrine,
right?
But isotope treatment is really growing enormously in all sorts of different types of cancers. So I'm sure that the education on the radiology side has also increased. And then even if you say, oh, well, you're teaching it up at this level, I think it's just logical to think that will trickle down to medical students that are rotating on those services. So that's a good point. I guess I probably walk that question back a little bit. It's maybe not changed the curriculum. It has indirectly exposed medical students and residents to neuroendocrine just because the treatments are multidisciplinary. So even if it's your medicine rotation versus your surgical rotation versus your radiology rotation, you'd probably end up maybe seeing, it.
Yeah, fair point for sure. Next question from Jim. We're going back to contrast question. And this is from Jim, who says, I'll see you on the 24th, doc. So this is a pre-visit question. My question is, with me also stage 4 chronic kidney disease, I can only get the gallium-68 due to contrast. At what point would it be worth the risk to do the MRI with contrast?
Yeah, I'm not sure that it would necessarily be worth the risk, other than I'd have to see what the PET scan looks like. The PET scan is effective, gosh, I want to say probably 90% of the time at giving us even subtle changes. The thing about the PET scan is we're banking on them remaining somatostatin receptor avid, but that, a good proportion of the time, that's exactly what it does. So we don't sit there and try to harp on the 5% where something may be different. But that I would also say that there are protocols whereby we can give gadolinium even in patients with chronic kidney disease. It's just that those protocols also have their thresholds whereby they'd say that the risk outweighs the benefit of what's that going to be. So then you'd say, well, why is the MRI so valuable? Well, it's very valuable for looking at subtle changes in the liver, but that's predominantly because a lot of times we're considering liver-directed therapies, which in someone with chronic kidney disease is also a whole world of conflict, because that also includes a dye. So then you'd say the PET scan is actually more valuable, because if it's clinically relevant disease, we would probably only be looking at things that were obviously like gonna change treatment, of which the menu I was talking about is kind of narrowing for the same reasons. So we just have to be careful. You never want the treatment of the disease to poke the bear of another disease that's more likely to be a significant driver of mortality.
Mm-hmm. Got it. Next question from Steven. Steven says, somatostatin, octreotide for prophylactic use. Do carcinoid liver tumors adapt to octreotide treatment requiring increasing dosage to prevent tumor growth?
So, well, not that we know. So what they're describing is something that we call tachyphylaxis, which is that tumors will accommodate. So that's no different than you can tachyphylax off of antidepressant medications, and the same dose just doesn't seem to have the same effect. So I wouldn't say, now that is somewhat outside of my scope, because I don't do a lot of the pharmacology, but I don't believe that we actually see that very often in neuroendocrine. Now, if someone says, oh, is it stopped working and that's why my cells are progressing? I think that drugs, so the way I describe it to people in my little simpleton way, is that it's like a little car and it's driving over your body looking for a parking space on these type of cells. And like a police officer putting a boot on the car, it's trying to pull that cell, keep it from spewing out the stuff that gives people symptoms, and mess with the mechanisms by which it divides. And it's very good at that. But that the drug is going to be circulating. And so therefore it may be bound or unbound. So the boot is on the car, the boot is off the car, the boot is on the car, the boot is off the car. And so, so there will be times where people will show signs of progression, but I don't believe that that's because they're tachyphylaxing off of the drug. It's because the receptor density on the cells may be going down, and therefore you don't have as much cell binding, or have more cells or more parking spaces coming up and not enough cars to have the same effect. The thing is that there was some trial, I think it was the Cornet trial, that was talking about escalating doses of somatostatin receptor inhibitor therapy. And that was the plan. That was the strategy before, was when one dose stopped working, you would just keep going up on the dose. And for the most part, what we found is that that's associated with a whole lot more side effects and not really that good at containing the disease anymore. So that's where you go back to the menu, because that is exactly what the PRRT trials were testing against. They were testing against an escalating dose of somatostatin receptor inhibitor therapy, 60 milligrams of octreotide, and comparing it to this radioisotope treatment. And it was hands down, it wasn't even a race. End of story. Like the curves could not be farther. PRRT won that race. So in general, and that's once again in general, because there are going to be patients of even mine that are more than the regular dose of somatostatin receptor inhibitor therapy, but it is a minority, because you'd have to be saying, why am I taking a strategy that kind of lost the race if they have somatostatin receptor avid tumors and this one is available, and that component of the types of treatments we have seems to be only evolving into something even more appropriate or effective. So.
Got it. Thank you. And thanks again for your question, Stephen. From Ruby, I'm trying to recover from another extreme gallbladder attack. At what point should someone consider having it removed?
Oh, well, we remove them all the time. So the problem with the gallbladder is whether or not it's serotonin related or drug related. The gallbladder is really sensitive. So we remove them in almost every patient that has a midgut, particularly a midgut primary tumor, because the carcinoid syndrome symptoms can often worsen gallbladder disease, and gallbladder disease is already really common. Now say, for example, okay, that's water under the bridge because you already had your operation. You may be NED and not on any treatment. I have a very low threshold for taking out the gallbladder. It's a minimally invasive technique. Even in people that have had a prior operation, we can get it out laparoscopically, but that you can have complications of of progressive gallbladder disease. And the gallbladder is not helpful enough for us that we would say, oh, suck it up for a little bit, longer. We have definitely had patients, especially when they've had their primary removed, but the gallbladder was left in place. So we're in surveillance, and then they may or may not have other medical conditions that make that tough, is that we still do everything in our power to take out the gallbladder. The one downside of that is that patients with mid-gut primaries and have their gallbladder removed, they may be at higher risk for getting some bile salt reabsorption issues that can cause some diarrhea. And so therefore, we just have that conversation with people, ahead of time. Usually your body is so redundant in a lot of those things that'll adapt over time. But initially, right after having it out, there may be some trade-off, but usually that sort of resolves itself over maybe 6 to 8 weeks.
Got it. Folks, we got just shy of 10 minutes left. We're going to keep plugging along. Got a handful of questions left. Christy says, and a few other people, is there any connection to NETs and crazy blood pressure fluctuation?
Yes. So depending on, so neuroendocrine is about, it's not about the aggressivity of the cell, because even the lowest grade, most well-differentiated tumor cells, they spew out stuff, but they don't spew out the chemical with the same regulatory methods that normal neuroendocrine cells do. Mm-hmm. The same triggers. You wake up in the morning, you go to work, you're stressed out, you eat certain types of food, is that you have this constant trigger that's stimulating those cells. Those cells are on overdrive. And so you get a higher than average, or a more robust reaction to that. Hypertension is one of the most common things. Headaches, the sweating, the lightheadedness, the palpitations, that's all because of this sort of surge in those markers with any given trigger. Now, obviously, hypertension is also incredibly common. So we never want to say, oh my gosh, it's got to be related to this. Right. But unfortunately, carcinoid can be associated with hypertension. The treatment of carcinoid can be associated with hypertension. So you're damned if you do, or you're damned if you don't. So I will tell you that sometimes if we believe that a significant amount of a downstream consequences related to the disease, we may decide to go to the menu of treatment options and actually treat, even if someone is not showing signs of progressive disease, because hypertension can also have downstream consequences that can be drivers of mortality. And so hypertension, I'd say it comes up not infrequently, but so do things like headaches. And,
so do things like what?
Headaches.
Yeah.
People complain of headaches or the palpitations. And so we talk about all the crampy abdominal pain and diarrhea, but that's, if you were to look on it, those may be 3 of the things, but there are probably 10 things that the vast majority of people will complain about.
Got it. Well, hopefully that helps. Next question from Cindy. Cindy says, what is the best monitoring for an NED, no evidence of disease, patient? Primary was a PNET with metastases to liver. Currently having yearly octreotide scans and bi-yearly chromogranin and serotonin labs. So what is the best monitoring in that situation or similar situation for NED patient?
Okay, so pancreas is one of the more unpredictable. And so we do survey pancreatic neuroendocrine tumors, even if they're not metastatic, up to 10 years. And I think that we all are going to agree with that. We may or may not agree on exactly what we use, but if you're saying octreotide scan, like octreotide scan, PET scan, I don't think any of us are using that. So I would say that uniformly, most of us that are concentrating on the liver and the pancreas, and some with a history of a PNET, are using an MRI. An MRI is the most valuable tool for looking at those 2 organs in particular, and that is because of the complexity of those organs and the ability of MRI to change the sequence to the point where you can see things clearer. And then you would say the blood work for PNETs is a little tricky, because often the blood work is never abnormal and therefore it is unhelpful. But I think the vast majority of us have gone away from chromogranin A. It's way too nonspecific. So if we were going to look at something, we look at something that's more neuroendocrine specific, like serotonin, 5-HIA, and pancreastatin. And then we have all moved away from the octreotide scan. It's a low resolution scan. It's really expensive to kind of not be that great. And we have moved towards the gallium-68 or the copper, of which those are both high resolution scans that are very much equivalent, even though I think people think that the copper is edge, but they're very much equivalent. They have some slight, differences that make them more or less valuable. So of all those things, I would have said the chromogranin A we don't commonly use, but we do use some blood markers, especially with people that are symptomatic. The MRI of the abdomen with contrast is what we will usually use for PNETs. We survey people with PNETs up to 10 years, even when they're non-metastatic. And so the metastatic would absolutely be up to that point. And more than happy to clarify that in more detail if she wants me to give a second opinion, because it's, at face value, it seems like it's somewhat antiquated what they're doing.
Got it. Maria has a question. She says, I take an SNRI, and it seems like that would increase my serotonin levels. Should I be checked for that? Would that be an issue?
No, that's actually also a great question for this type of program. As you can imagine, serotonin receptor inhibitor therapy would have been very controversial in someone that was on a serotonin reuptake inhibitor. No, that has been studied. It is 100% safe. And although I'm going to admit to you, I don't quite understand it because it seems absolutely counterintuitive.
Right.
But the serotonin reuptake inhibitors are predominantly in the brain. I'm not actually sure how they measure that though. So therefore you're like, well, how do you know if it's in the brain? It's in a thing. What I have been somewhat concerned about and reached out to sort of neuropsychiatrists is that we put someone on serotonin inhibitors and you will have people that have really low serum serotonin levels, and low serotonin levels are what is actually linked to depression. But once again, it's low serotonin levels in your brain and not in your thing. But there are some neuropsychiatrists that have said that when people run extraordinarily low serum serotonin levels, it likely is going to be somehow impacting mood.
Yeah.
But that I'm not sure what we would do about that, because I've got a cancer diagnosis for which this is the standard of care treatment. So how do you balance that in someone that may or may not be having those problems? Once again, long answer to short question. Perfectly safe for you to take a serotonin reuptake inhibitor. It has been studied for that very reason, and there's no controversy to it at all.
Awesome. Thanks, Maria. Hopefully that helped. Dr. Maluccio, one more question I think we have time for, and I'm interested in this. In the beginning of the program, and even before we started recording, you and I talked a little bit about clinical trials. Just as a broad question, can you talk to me a little bit about your thoughts on clinical trials, the importance of them? I know when we were chatting about it, it was specifically about people with not a lot of access, right? People in the rural South specifically. Talk to me a little bit about the importance of clinical trials and what or how one should approach that if they're a patient.
Okay, yeah. So clinical trials are super important. So I think what people don't quite understand about clinical trials is they think of that as always being experimental, or that's something that is untested, or I'm going to be a guinea pig or something like that. And I just want that is unequivocally not what clinical trials are. So for marginalized patients and rare cancer patients, what is available on a clinical trial may actually be better than what we currently have available to you, but that because it has not entered FDA regulation, or it's coming from Europe, say, for example, and with PRRT coming from Europe, is that the only way that you would be able to get access to those types of therapies that may be very appropriate for you would be through a clinical trial. So yeah, I'm really passionate about clinical trials because there's certain parts of this country where patients are just completely left behind. They have no access because they either don't have the insurance to do it, don't have the means to cross state lines, and therefore they're just not even going to have that as an option for them. So one, I think, very profound example of that is that people that are on some of the managed Medicare or the Medicaids or whatever, well, for whatever reason, no judgment on, federal government, whatever, but that they don't even have access to what is currently considered the standard of care.
Right.
So they don't even get PRRT. So in certain parts of the country, like the South, the only way that I would be able to some people with the tried and true would actually be to have it under a clinical trial. And I think that, like many things in neuroendocrine, industry is also interested in this. I mean, they are interested in partnering on behalf of patients, but that they also can't just do it willy-nilly. We have a regulatory system. So clinical trials are important. Yes, some of them are testing things that have less data behind them, but may make sense. That some of the immune therapies, for example, but the whole point is having them at least available so you can have a conversation to see how that may be applicable to you. But for rare cancer patients, I think the access and our building clinical trials is important. I think if you were to ask any of the academic neuroendocrine programs, we're all like, yes, yes, yes. We need more clinical trials and we need them available in a broader area.
Awesome. Thank you for that. Dr. Maluccio, a couple times today, you said, several times today, rather, that was a long answer for a short question. Well, Scott says, I appreciate your detailed and thorough explanations, and I have to agree with him. That's the way we're going to frame that. Instead of long answers, they were detailed and thorough. So Scott, and probably everyone else in attendance as well as myself, appreciates those. Thank you so much for being here. That's our time for today. We really appreciate you sharing some space and time with us, and a lot of great, valuable information.
No, and it was great questions. Loved being here.
I told you they would bring them. And folks at home, thank you again, as always, for being here. And we hope this program helped answer some of those questions. And if you have any follow-up questions or didn't get your question answered, you have two options. Reach out to CCF here or at carcinoid.org, or here on the Facebook page. You can private message them. And the second option is to tune in next week, because we're here every week, so you can get those questions answered. But we appreciate you being here. We had great numbers today. Says a lot about our guests. It also says a lot about your dedication and commitment. We appreciate you. We are here for you. Thanks again to our presenting sponsor, Ipsen Biopharmaceuticals. We could not do this program without them. And finally, my name is Rain Bennett. I have been your host. Thank you for watching. Please join us next time on Luncheon with the Experts. Stay healthy, stay safe, everybody. Bye-bye.
Bye.